Looks like we should be live here soon. I'm just getting the Instagram on. If anyone can see this, I apologize. I know the Sperm Meets Egg website is down. There is some issues we're having with the name servers, and so that needs to be fixed. So again, if anyone's having problems trying to watch it there, you can always go to our Facebook pages, Dr. Salem's Instagram pages, our Instagram page, pretty much everywhere you can go. It's just unfortunately you can't go to Sperm Meets Egg tonight. I will put the if people want to come on the show, I will definitely put that in the top here so people can as a banner so people can know to go. But anyways, so tonight we were going to talk about endometriosis, which is one of the biggest enigmas in fertility. It's probably one of the biggest enigmas even in medicine. And so this should be a fun discussion tonight. I really would hope, and I know Dr. Salem agrees, we'd love to really hear from people and hear your questions because ours are going to be probably pretty, nerdy, the things we're going to talk about. But I thought if you want to start first, Dr. Salem, and kind of, give your view on endo and things that, we want to talk about, and we can kind of go from there.
Yeah, no, definitely. It's great. It's great to be here again. And I'm glad we're back on live here with Sperm Meets Egg. And it's great to be with you and with Ari and getting to talk about, these topics again. And this is one that it's kind of it's an enigma. I think that's a great way to put it, because even though we understand so much about, women's health and fertility, and so, all the various reasons for fertility treatments, endometriosis is still one of these that is kind of honestly poorly understood. Like, we still don't know exactly what sets it off, why it grows more in some people than in others. We think we know all the ways it causes infertility, but we're not even 100% sure about those things. And I'd like to kind of kick this off by talking about when I first learned about endometriosis. This probably goes all the way back to early medical school. And the way I was hearing about it was there's this inflammatory disease that the cells are spreading, but they're not like cancer, but they're spreading in places they shouldn't be spreading. They're outside of the uterus, the lining of the endometrium where they should be. They're on the tubes, the ovaries, the peritoneum. But then I started hearing about these case reports where you could even have endometriosis in your lungs, in your nose, and all these things. And I was like, this is a wild disorder. I mean, the fact that this tissue can implant in these places so far away from the endometrium, but at the same time, it's definitively not cancer, right? So it's not growing out of control entirely. So I thought, that for tonight, it would be a really important topic to discuss, what we know about it historically, how we treat endometriosis, the big picture stuff, and where's our field going? What are the new advances that are hopefully going to lead to a lot of, therapeutic interventions to rid people of this really unfortunate condition that, by the way, takes forever to diagnose. I mean, the average time till diagnosis for most women is almost 10 years on average, from the time that they report symptoms to the time that they actually get a formal diagnosis, which is way too long. So, I think for right now, I'll leave it there, and I'll kind of let you give us your kind of 2 cents, first flavors of what it is that you're thinking about.
It's interesting. When I first learned about endometriosis too, I was it was this weird enigma going like, what? Like, tissues growing in the brain? Like, I mean, it's been found in almost every compartment in the body. And when I first thought about it from a fertility standpoint, I only understood it as almost like a disease affecting the tubes. And it wasn't until later that I realized the main factor of this disease is the inflammation and the hostile environment it creates, in the pelvis, leading to infertility. And so I've seen people with just a little spot of endometriosis and struggle to get pregnant. And then I see people who, were just doing the surgery for a different reason, has endo everywhere, has no problems having kids. And so when we talk about this being an enigma, it truly is. I mean, we really don't really understand it that well, We don't understand then why in some people it's worse with less tissue, and with others are doing fine with a whole bunch of endometriosis. There's people walking around today that don't even know they have endo, have no symptoms, and if we went and looked inside their abdomen, we would find it. Yeah. And so there's this balance between first getting endo, then there's this balance between the body's immune system and how it interacts with the endometriosis, and then the way it interacts is able to get rid of it. All these different things are happening, and so what's weird is that this is the craziest thing about humans. I always tell people is that you can do the exact same thing to two people and get two different results, and the same thing we see with endo. And so it makes it very difficult to treat because there is not one treatment for everyone. I'm sure you've seen that yourself, Dr. Sandlin, where, the answer isn't always IVF. Sometimes the answer is surgery. Sometimes the answer is suppression. I think for people who are coming on here and don't know about endometriosis, to keep it really simple, as Dr. Sandlin said, it's essentially when the tissue inside the uterus grows outside of the uterus. And again, that's usually in the pelvis is the most common place, but as he mentioned, it can be in other places. And there's two ways of thinking with treatment. I'm a fertility doctor, so I think fertility, but there are people out there with severe pain, poor quality of life, who are wanting treatment for that reason. And then there are people who are trying to get pregnant, which is where we come in, but we also do treat people just for poor quality of life due to their endometriosis as well. It's a really weird disease. I mean, there's not really much like it. It's quite invasive, but it's just so strange that there can be this huge spectrum of different types of sequelae that people have when they have it. And I saw a patient today who she had endo but didn't have much, and then saw some other day who had stage 4, and she said she really didn't even know she had problems, and then she went and had it treated, and she said her life was so much better, and she didn't even know her life was bad because she thought that was normal, and that's what a lot of women think when they have these painful periods. They're just told, oh, your periods are going to hurt, and like you pointed out, that's one of the major things. I think I read something before, like if you have severe pain with your periods and infertility, you're like around a 70% chance of having endometriosis, so it's quite common. The other thing is genetics. I mean, there's clearly a genetic component here. This is why we ask if you have family members that have endometriosis. When you're doing your workup, what are you looking for, Dr. Sam? Are you looking at like the family history and things like that as well?
Yeah, no, definitely. I totally agree. I mean, I think that, the history, just like we all know very well, but the history tells you so much. Of just listening to our patients, usually they'll give it away, and very oftentimes they'll tell you something like, when I was younger, adolescent, going through my first periods, I noticed that they were, pretty painful, or they were really painful, or I was missing days of school when I was in high school or college because I was having these really painful periods. I couldn't go to class. Other women will tell you, hey, I was having these really heavy periods and they put me on birth control, and it made it a little better, but it didn't really solve the issue. So I feel like going way back to the history of when, a lot of women were younger, like how did that present for you, and really listening to their story, there's a lot of clues in there. But definitely we know there's this family component as well. It's not fully hereditary. It's not like 100% hereditary, but it does cluster in families, especially if a sister or two sisters also have endometriosis. It's amazing how oftentimes that other woman has endometriosis as well. Yeah. There's been some interesting study, almost kind of like trivia things that have had a relationship with endometriosis, like a nickel allergy, or some women saying they have an allergy to, cheap metals of jewelry. Either that or they're trying to trick you into, getting nicer jewelry. But I'm going to go with the endometriosis. But, so there are some kind of interesting correlations there. A lot of women will also sometimes have this history where it gets confused with other systems entirely. Like some people start thinking they have IBS and they have like irritable bowel syndrome. And really they're just having all this inflammation around their time of their period, because what's happening is those cells, those endometriosis cells, are reacting like their period, but on the inside of their body as opposed to the inside of their uterus. And so there's all this inflammation. We call, some people, these are not my words, some people have called it like a toxic pelvic cavity. And that is part of the disease process there. But no, I agree. I think this family history component is really huge. And I think that's the clinical piece. But I'd be curious to know, because, the holy grail of endometriosis is an easy test to diagnose it. And that has eluded us. Like, we can't really very easily diagnose endometriosis. And I'm curious, like, Dr. Amos, like, when you start suspecting endometriosis, how do you go about thinking of how you're going to try to diagnose it, or if it's even important to diagnose it?
Yeah, and I think that's where you hit the nail on the head. I think you have to look at from a holistic standpoint, right? Where is the patient? Are they in pain, right? Are they having symptoms? So if someone's having symptoms and, they say they have pain with periods, they can't have relations with their partner without, being uncomfortable, and they have infertility, even if I don't see it on an ultrasound, so I'm not seeing an endometrioma, which is a common sign that you can see, then I may say, listen, it may be worth doing a diagnostic laparoscopy to look further into this, because we're going to kill two birds with one stone. One, we're going to be able to potentially help your fertility, but two, we can give you a better quality of life if we find anything. So I kind of go from there. If there are no major symptoms, but I still suspect it, right? So like a family history, maybe they have painful periods, but no dysmenorrhea, dyschezia with pain with bowel movements and stuff like that. I may say to them, listen, I think you have endo. I don't know if you do, but I don't think it's worth doing the surgery. Let's just be, whatever we do, we're going to be a little bit more aggressive. So I might want to make more eggs, because I know the environment may not be as good. And that's kind of how I look at it. There was Steve Brooks, who was actually asking a question a while ago on one of the shows. He got me in touch with one person, and they were doing some pretty cool research on endo, where they were looking at markers and be able to, basically determine with high accuracy if someone has endometriosis. Now, it's not prime time yet, but there are some things coming around, and I think that's going to be really useful, because, helping diagnosis is part of it. The next question is, and then this is where I feel like even if we diagnose it, do you do something? Because some of the treatment can be worse than diagnosis. So, for example, I know you and I've seen this where, someone has multiple surgeries, right? So they have surgery every couple of years and they feel better, but then it starts getting to the point now where the surgeries get complications, or in the situation where a lot of their ovaries have been removed and now they have diminished ovarian reserve, and now they want kids, but they've had 6 surgeries and now their ovaries not as good. It makes things hard. And so I think what the Holy Grail, as you were talking about, is not just knowing if they have it, but do they have the type that's going to affect fertility? Do they have the type that will benefit from surgery, or will they benefit more from Orlissa by taking a medication, or Lupron? Like that's the hard part. You and I had this discussion recently about when people have positive receptiva. As we all know, you can have endo and have a negative receptiva. A receptiva test is just saying that the endo is affecting it. But the question is, what's the right treatment? Do you do surgery? Do you use Lupron? Do you use Orlissa? I don't think anyone has the answer of like what's better or something like that. And there might be different for each patient, right? There's some that maybe it's that Orlissa will work better than for someone who would be doing surgery. And that's the hard part with endometriosis, that we act like experts, but we're really only the experts of very little knowledge, right? So we don't have the full knowledge yet. And so we are quite stupid in some ways when it comes to endometriosis, where they're doing the best we can with the limited information we have.
Yeah. I mean, I think that probably endometriosis has quite a few different genetic subtypes, and that the different types affect fertility in different ways. And I don't know, I thought since we're doing this and we have some time, maybe we can kind of talk through some of the different treatments and kind of, unpackage those a little bit. Because I think there's a lot of questions out there about, what types of surgeries exist for it, what types of medical treatments exist for it, and then of course what types of fertility treatments exist for it. And I thought maybe we could start just with surgery, because that's the classic one, right? Before the days of ART and IVF and all this fancy stuff, the age old paradigm was look in there, right? Almost every infertility patient would have a diagnostic laparoscopy to look to see if they had endometriosis. And we don't really do that anymore, in large part because of some studies that showed that that doesn't get you that much. That doesn't get you that much. You end up taking a lot of people to surgery just to look, and they don't have endometriosis. But the other part of it is, the surgery itself, when you take a look, if you have really extensive endometriosis, that's a very technically challenging surgery. And so I think it's important to reflect on that for a second. The first thing is that a very complicated endometriosis case should probably be done by somebody who does a lot of endometriosis, somebody who's really good at either laparoscopy or robotic assisted surgery, because you're operating in very sensitive areas. And endometriosis is messy. It's like you have chewing gum and you've just stuck the gum everywhere, and everything is kind of stuck together. And it takes a really good patient surgeon to kind of, dissect all of that little by little safely. And that can, historically, that can help with symptoms of pain. And in some situations, it can help with this kind of toxic peritoneum and toxic pelvis, and kind of reduce the amount of endometriosis that's there. Now, interestingly, on this question of surgery, people that have endometriosis and have had surgery for it versus those who haven't, when you do go down the line and you do IVF, they have the same rates of genetically euploid embryos. So it's interesting that endometriosis doesn't lead to a higher rate of genetically abnormal embryos, but it can lead to this inflammation and all these other things that we were talking about. So surgical management, laparoscopic, robotic assisted, open. Some people still open if they have to. Sometimes you have to open to do it. But the key is optimal debulking, right? Get as much of this out as you can. And in the hands of a very proficient surgeon, she will be able to do that and really kind of lead to a very good outcome with that. What do you think? I mean, other thoughts on surgery?
Yeah, funny you say that, because I had a patient today who also had, severe endo, and I said to him, I said, if you needed to do surgery, do not go to just a generalist. Make sure you go to someone who is specialized in this with your stage 4 endo. I've seen people with stage 4 endo go under surgery, and the doctor goes in there and pops an endometrioma and then leaves. And that's because that was good for them to do, because it was too dangerous for them to try to do the real surgery because they weren't comfortable with that. But in the surgery, they have to go into what's called the retroperitoneal space. And if you're not comfortable with that, you can cause major bleeding. You can injure the ureter that goes from the kidney to the bladder. And what a lot of people do when they do the surgery, unfortunately, is they go in there, they only look at what they can see, and they either burn it or they remove it. Whereas like where I was trained at Mayo, we go and we, as you said, debulk it. We remove all the tissue around it. And then if we don't see it, we still take biopsies in those areas, because a lot of times you can't see it, but it's still microscopic in there. But I agree with you 100%. I'd say like a MIG surgeon, so a minimally invasive gynecological surgeon, it could be a generalist, but it just needs to be someone who's specialized in, who can do those cases. Gynecologists are really good with it. The problem is, and then as you know, is when you get to gynecologists, then you start getting to the doctors who forget about fertility, right? And so now you run to this issue of, oh no, now they're doing a great job of getting my endo, and they did a great job. I have no more endo, but I also don't have ovaries anymore. And so there's that fine line of finding people who preserve fertility. That's why I think reproductive doctors are definitely some of the best to do it. The problem is that, not all of us always do it all the time. I mean, I used to do tons of surgery, and I did all the tough cases when I did them. And I mean, I'd be in surgery for sometimes 3 hours, doing a laparoscopic case. I don't do those anymore. I don't have the time anymore. And so I send them off to other people. And so it is starting to go more to the MIG surgeons, which are minimally invasive gynecological surgeons. And I think if you have a fertility doctor, they'll only recommend people who are going to preserve your fertility. And that's what I do when I talk to them. So great point. I think that's that one point to bring in, is that, yeah, it's important to do the surgery, but it's also important to have someone that goes, okay, I can breed this a whole bunch, but she's 40 years old. if I go and I remove this endometrium completely, she's going to lose half her ovary. I'm going to back off. And that's the point I think that's important. I know, and I do agree with some of the things we should go over. I think there's a lot. I see we do have someone who's waiting to talk to us. I'd love to hear questions because, I mean, as usual, you and I are saying what we think people want to hear, but our questions really are going to help us more. So, Larissa, we're going to get you on air here.
Hi.
Hello. How are you doing?
I'm great. Gosh, you guys are blowing my mind right now. All this information. I wish I had known last year and 2 years ago. I've had 2 surgeries. So I actually submitted a question through your online portal. And I think you pretty much answered it. Basically, you said that each patient is different with the treatment going into IVF. And I didn't want to get too detailed into my case, and you had already put something on your comments. Don't go too detailed into your question, so I'll stay away from that. But I guess is there anything that patients can do in their daily lives to help with bringing down the inflammation or being more proactive? I mean, medication aside, I'm very holistic with food and supplements, and or do you believe in any of that? Exercise, anything, or is it all just, well, what you got in there is what you got in there, and it is what it is, and you're stuck?
Yeah, and I'd love to hear a little bit about your case. I mean, if you want to tell us a little bit about it. You said, I mean, it sounds like you've gone through 2 surgeries already. Sounds
Correct.
like it's a pretty significant case if you've had 2 surgeries already.
Yeah, stage 2. My most recent one was just in April, but I'm already experiencing pain again.
I'm sorry.
So, and of course, I turned down the hormones because I was afraid it would affect my ability to conceive. And I've had bad reactions to the Orilissa, bad reactions to Lupron. So I thought, okay, well, let's try the holistic approach and something else maybe instead of another surgery, because obviously that's not working. I don't know.
And can I make the assumption, Larissa, are you not trying to get pregnant right now? So right now it's more for, quality of life right now?
No, we've been trying for 3 years.
Okay, I just wanted to make sure I didn't misunderstand that. So, okay, so it's in the idea of that. Yeah, I mean, this is exactly what we were kind of talking about a little bit earlier of how, you get patients who, you put them on birth control and they feel amazing. They have endo and they feel amazing. And you're like, wow, birth control did it? And then you have patients like yourself who have basically used every gamut of medical therapy we have now, and it's not working. And it's tough because, as you probably have learned, Larissa, and Dr. Simon can say, a lot of the treatments that treat endo go against fertility. And so it's like, which one do you want, a baby, or do you want to have good quality of life?
Yeah.
That's a hard trade-off.
Yeah. It's one of these, crazy things. I remember the first time learning about this, they're like, you gotta pick either, do you want a baby or do you want to treat your pain? And I was like, wait a second. Why can't we have both? It just seems like if you're treating the endo, you could have both. And this is the limitation of where we're at right now with the science. I mean, the real treatment would treat both.
Yeah, exactly.
And I've actually been told by a couple of physicians, well, just hurry up and get pregnant, then we'll scoop everything out and you won't be in pain anymore. What?
And that's not always a great treatment too. I've met many patients who have had their entire reproductive organs removed and have not had complete benefit. They've had some, and there's no question once you remove the ovaries, I mean, it does make a huge difference. But there, like I said, there's complications from all these surgeries all the time too. Yeah, it's a great thing. We're going to go over all those different things. Anything specific? Like it sounds like you've tried. I'm assuming like all the medical therapy, like the ibuprofens. You've tried the birth control. You've tried Alyssa. You've tried the AdBac therapy with Lupron.
All of it.
Yeah, there used to be a really old drug that people used to use. I don't even know if they use it anymore. Which was like it was like a male porn. It was before Lupron came. And I've used that in like the worst cases. But it has a side effect, which is it causes girls to get hair like on their face and breasts and stuff, which most women don't want that. But Danazol was something we used to use. And like I said, it just shut everything down. But it also was a very androgenic hormones sometimes, but that was one thing I used in someone who failed everything. She's like, I'm willing to do that if I can have a good quality of life. But well, I'm sorry to hear that. Like I said, it's. I think the most important thing is when you've had the surgeries, have you done the treatment right away? Like in other words, when you have the surgery, are you getting put on their Alyssa right away if for comfort, or are you trying to get pregnant right away right after the surgeries?
After the first surgery, I was put on the birth control right away.
Yeah.
And the pain came back within 8 months. Yeah. This last time, obviously, she did not put me back on the hormones because she knows that we were going to do an IUI or IVF right away. So she didn't put me on anything.
And do you mind if I ask the pain, and I don't want to get too private to them, but are we talking pain like pain with bowel movements, pain with intercourse, pain with your periods?
It's just daily pain. It's where my ovaries are located on both the right and the left side, and it penetrates to my lower back. Yeah. And that's where she scraped it out too. It was on the right, left side, and it was where my bladder is as well.
Yeah, that's
yeah. So sorry you're going through this, Loris. I mean, one of the things just to chime in here is, and thank you so much for sharing this story, because I bet there's tons of people listening and that will listen that will share this story with you. One of the things we know about endometriosis is it grows back. And a person that needs one surgery for endometriosis, very oftentimes, if they're doing it a long time before they go through menopause, which is mostly when women are trying to get pregnant, will need to have, recurrent surgeries for their endometriosis. But so I'm just saying that to, reassure you that you're probably in familiar territory now. It's unfortunate it did come back kind of quickly. Some women, they'll have a long period of time where it doesn't come back, 5, 6, 7 years, then it'll come back. And that's historically, that's been the idea behind being on some medical therapy to suppress it, keep it at bay after your surgery. From a fertility standpoint, definitely we do see those highest fertility rates right after the surgery, and that 6 months to a year after the surgery. But I know you had some questions, so I'm not ignoring those. We'll get back to those, but I'll bounce it back over to you, Dr. Amos.
Yeah, so just from a fertility standpoint, just so I have a complete understanding. So what did you do for fertility treatment, just so I understand?
We did an IUI.
Okay. Are you guys just one IUI or multiple?
We just did one.
Okay. And any next steps now that you spoke about with with your provider? Yes.
We are scheduled to do an IVF consult tomorrow, actually.
So one interesting thing is, when it comes to IVF and endo, is there's this kind of thought that when you bypass the pelvis, right, you're kind of removing these eggs from the pelvis, and so that environment that they're growing in might benefit them. And as Dr. Salem just mentioned, it's not going to change the DNA of the egg. So if it's aneuploid or euploid, it's not going to affect it. But one of the questions we've even asked by someone is, does it impact the egg quality? And the answer is yes. I mean, there's no question that when people have endo, the egg quality ends up being a little bit poorer, especially like if you get into it. Like, so for example, for us, when we're doing a retrieval, if we get into an endometrioma, we'll change out the whole needle and everything because we don't want to expose the other egg. So I try to stay away from the endometrium the entire retrieval. and then I try to get all the eggs, and then the very last one, I'll probably, if it's near like the endometrioma, I'll go near it. So that way, if I just accidentally get into it, at least I didn't expose the rest of them to it. And so we keep that in a separate dish, even as it. So we do know it affects it significantly. We don't know if it's the endo itself, or is it the response to the endometriosis that's creating the inflammation, and then that inflammation is then affecting, because we know inflammatory factors absolutely affect the egg. So the good news is that there is some hope there. And the nice thing, Larissa, is that sometimes when people get pregnant, they do better. Not everyone does, but most patients, when they get pregnant with endo, do a little bit better during the pregnancy, because pregnancy is like the biggest birth control you ever be on in your life, so it just kind of like makes everything stand still. But well, I really hope, like I said, that you have success. It sounds like you're going in the right direction. We're going to talk about a couple of things coming up in the future. There are some treatments that people are looking at. Unfortunately, right now, it is very limited to some of the things we've already talked about. I think Dr. Salem and I will talk about some other ones as well. But any other questions before we go? And then we're going to kind of hit those questions you said about what are the treatments? What other things can you do for endo?
Just one more. When regarding IVF, when you are when I start that and I'm taking all the hormones and preparing my body, obviously my body's already inflamed. So how do you monitor somebody who's inflamed? They're on these hormones. You're going to do the retrieval. Does that affect what you do when you're going into an environment like that? I mean, do you treat? Is it more difficult? I mean, is it just because that's been my biggest fear is I'm constantly inflamed. I also have autoimmune, so that doesn't help. So I'm constantly inflamed down there. Is it even possible for the eggs to grow, for them to retrieve the eggs, for them to even put an embryo in? So because it's just crazy down there.
Yeah. Well, I mean, the simple answer is yes, it is possible. I can tell you that. Back to that point where we said every person is a little bit different, right? So someone who has a giant endometrioma, we're going to approach it a lot different than someone who has no endometriomas. Dr. Salem, for example, one thing that I like that he does is he'll have people on Femara the whole time to keep their estrogen levels low. I put people on steroids to keep the inflammation down. You actually mentioned autoimmune. Autoimmune is very common with people with endometriosis because, again, it's that autoimmune kind of condition, not recognizing its own tissue and reacting to it inappropriately. So, it might be good if you're able to stick around. We'll kind of answer some of those questions, and then we may come back and if have other people, and you can see if we answer them well for you.
Okay, appreciate it. Thank you, guys.
No problem. We're just going to let that.
One of the other things too about that Larissa brought up there is this idea that there's all this inflammation. I mean, the way she describes it, I really appreciate it. She really paints a really good picture of what it feels like to have endometriosis, and I think, just feeling like there's all that inflammation down there. And that's because there are all these inflammatory mediators that we can measure in the pelvic fluid and the perineal fluid. And long story short, just to kind of think about this, in a more simple way, one of the really revolutionary things about IVF is that we say, okay, we get it. There's all this inflammation in there. Let's not create the embryo in there. Let's create the embryo where we know there is no inflammation in this IVF lab over here, where there is no endometriosis. And we take the eggs out of that environment. We take the sperm out of that environment because ultimately that's the only other place for them to fertilize would be within the body, within usually the tube is where they fertilize. And there is exposure to all these inflammatory mediators. So I do think that is one of the hallmarks of why IVF works so well for couples that have endometriosis.
Yeah, I agree 100%. And, I never recommend IVF just because of endo, but there are times I have. I mean, there's, patient comes in and they're trying for 6 years. And then I go and I do an ultrasound and I see endometriomas and I'm like, okay, clearly endometriosis. If they're not wanting to do surgery, I said it might just make more sense to jump to IVF because if you haven't got pregnant in 6 years and the sperm's normal and, you have endo, it likely is going to require that. On the same token, though, we talked about there's the case where someone, has a little bit of painful periods and, they probably do have endo, but, we can't prove it right then and there. We're not going to do a surgery. I'd say let's start with IUIs. And so back to Larissa's point, how we approach it, that depends. There's some evidence out there with endometriomas. Once they get above a certain size, like 4 centimeters, there might be a benefit to removing it versus doing the IVF. And that's because when you're coming in with the needle, you're going through the vagina into the ovary. But the problem is, if all the eggs are in the front here, you can get to all the eggs without going to the endometrioma. But if this giant endometrioma, you have to go through it to get to the eggs. And we just got to talk about how that is toxic to them. And so that can cause issues. And so there are times it's actually better to remove the endometrioma. But then you take into things like the age of the patient, or how many surgeries they have, what their ovarian reserve is like. And those things play a part. Like I said, Dr. Sam, one of the things I think that's really cool that you do is I know sometimes you'll do Femara throughout to keep the estrogen levels low. And I think that brings up one of the questions from that was, does endometriosis affect estrogen or progesterone levels that can lead to infertility? And so, honestly, it doesn't cause those levels to change, but those levels can affect the endometriosis. And so I'd love to hear, if you want to answer that kind of question for Fiona about that, how does estrogen and progesterone affect the endometriosis when going through an IVF cycle? Like Larissa was asking, like it's going to affect it when they're going through it.
Yeah, no, definitely. I mean, so I think one way that I like to think about this is that, endometriosis is almost like, imagine that endometriosis is like, weeds in a lawn. And if you put a lot of fertilizer on those weeds, the grass will grow, but so will the weeds. And the endometriosis outside of the endometrium or outside of the uterus is kind of like just having weeds without the grass, but you're putting fertilizer on it with those estrogen levels. So estrogen and progesterone, they both can increase the growth of the endometriosis over time. And that's why we generally will see that as young women go through the course of their reproductive years, that the endometriosis can sometimes, grow, can get more severe, or it can grow back. So the flip side of that same coin is when a lot of the surgeons or a lot of the, reproductive surgeons and doctors, what they try to do is they try to take away all the endometriosis, and then they try to give medications that block the formation of the estrogen. You're trying to block the formation of giving that fertilizer in the first place, so you don't get any new growth of the weeds, of the endometriosis. And so it's kind of a two-step approach to getting everything out of there and then keeping it from growing. But then, of course, naturally, if you're not on these, on birth control or medications that prevent the growth of the endometriosis, it will over time, grow little by little. So what we're just trying to do is slow down that growth to give you a window of opportunity. So, okay, going back to what you're talking about, Dr. Amos there, this idea that, when we go through IVF, you have a very short period where the estrogen levels can go up a little bit higher. The estrogen levels not in the ovary, but outside of the ovary. We want the estrogen levels in the ovary to be high. And so one thing that, we can do is kind of quickly get those estrogen levels low or lower outside of the growth phase of the IVF cycle. And so kind of trying to, again, tamp down that growth from the fertilizer. We're trying to remove that fertilizer as you're going through. But it's a small step, but it's one step that when added into an IVF cycle may make a difference. Like, we don't have perfect data on some of these things, but it may make a difference, especially going after the cycle of IVF. One thing that I've noticed just very anecdotally is that women who are on that type of a protocol who have endometriosis generally tend to say that their pain after their retrieval was a little bit less than those sometimes who had more, had those higher estrogen levels. And some of it has to do, by the way, with just the mechanism by which endometriosis takes place in a couple of the hormones within the process of endometriosis that actually in and of themselves increase estrogen levels. So I think that these are kind of approaches that we like to think creatively about. How can we really address multiple things at the same time?
Yeah, I mean, really, no doctor should be doing the same treatment for everyone. There's just so many different ways endometriosis can be shown. I mean, even when someone is not trying to get pregnant, for example, if I see someone who comes to me and I suspect they have endo, but their only pain is during their period, and they never have pain any other time. So like for Larissa, it sounded like she has pain all the time, and that's horrible. And that's a little bit different. That's where surgery really does come into play. But if they only have pain with their periods, I put people on birth control, give them 1 or 2 periods a year, and they're happy. And so there's somewhere where I treated endo, but I didn't have to do anything else. So it should always be an approach based off of the patient's symptoms, what they're going through, if they're trying to get pregnant, not get pregnant. I've never had endometriosis. Obviously, I don't have a uterus. I think hopefully it's obvious, but if it's not, I don't have one. But what's funny is I've had varicocele, and I can tell you, like, it's achy sometimes. Like, I mean, it's really uncomfortable. Like in that pelvic area, I'm just like, man, it's really uncomfortable. And I wonder if that's what endo feels like. I should ask Larissa, like, is it just this constant discomfort all the time? And I feel like, man, like I wish I could just turn it off. And so, I know there's some people who have severe pain. So there's people who have sharp, very bad pain. I have to like go to the ER type of pain. And then some people have just very achy pain. One of the really interesting things that is kind of taking a tangent here that people may not realize is that when you have endo, you have so much pain all the time that you start adjusting things in your pelvis. So an example is now your pelvic muscles get a little tighter. When you have intercourse, things get tighter. And now all of a sudden you start developing other forms of pain. And so we call it dyspareunia, meaning pain with intercourse. And you can start getting what's called pelvic floor myalgia. So now all of a sudden your body reacted so long that now the muscles are tighter now. And so now even if you treat the endo, you still have some of that pain. So then you start creating these secondary pains. It's really important, I think, and I think you agree, Dr. Salem. I mean, if you ever suspect you have endo, never be afraid to ask them. If you're having pain with intercourse all the time, that's not normal. If you are having pain with your bowel movements around your period, that's not normal. And if your periods, when we tell people, like, of course, you got a little cramping, but you should never have pain with your periods so severe that you can't like go to work. If it's that bad, it's not normal and you really need to be checked out. And again, doesn't mean you need a surgery. I think one of the questions that was asked was by Amanda was, if you have no indication of endo, should you still get checked for it going through fertility treatments? And I think you and I would both say that no, that if you have no indication of it, it doesn't mean your doctor isn't thinking about it. Every single patient I see, I think endo. But just like anything, you're looking at from the standpoint going, okay, 100% this person has it, and probably less than 5% they have it. And so I'm always using that sliding scale to go, how much do I need to be concerned about it? And every time those symptoms come in, I go, okay, I'm more concerned. I need to at least be thinking about more and treating it more. And the way I treat it is I will be more aggressive in treatment sometimes. So I'll say, okay, I got to make more eggs because I know her quality might be poor or something like that. But back to the point of what I was going with the different types of treatments is that no doctor should be doing just one treatment. It should always be adjusted to the patient and what their problems are. And I can tell you, Larissa, I would have a tough time with your case too. I mean, it sounds like a very, very difficult case. It's one of the ones that just seem to be not respondent to a lot of the treatments we have. And then unfortunately, right now, those are kind of the mainstay of treatments. And like I said, other than going to like Danazol and stuff and going to these, really off-label treatments, it's like I said, it's a tough case. Remember I mentioned Steve Rooks earlier. I was like, he comes in here. And so I saw him ask a question, and he was actually talking about one of the things we were talking about, which is they really are coming out now with non-surgical ways to determine endo. But for me, and I'd love to hear your view on this, Dr. Salem, it's not just about having endo though, right? I mean, again, we may find out someday that 90% of women have endometriosis, right? But that doesn't mean that it affects them all. And so the question is that, is a test now going to put this mark on the patient, and now they're freaked out that they have endo and they're going to have problems, kind of like the Receptiva test is. I have every patient I know who has endo, like, oh, do I need to do a Receptiva? And I say, no. I have people with horrible endo, and I do a transfer routine the way I do for everyone. Perfect. Gets pregnant right away, no problem. So we know that the endo itself doesn't affect everyone the same way, right? Just like adenomyosis, could cause effects. So I don't know. What do you think on that? That even if we come up with a non-surgical diagnosis, and we can diagnose everyone 100%, what do we do with that information, though? Does that mean that everyone's going to have a problem? So,
yeah, I mean, that's like the golden question too. And I think as the test becomes easier and easier and easier and cheaper and cheaper and cheaper, it becomes a little bit easier to justify doing it. But then it's kind of like, well, what are we going to do with that test? Or does that change our treatment? I guess I would make the argument that if the test is really, really easy and really cheap, I mean, there's a few companies out there that are doing totally non-invasive testing, like in the menstrual blood, they're looking for like microRNAs and various kind of molecular fingerprints that may be consistent with endometriosis. And maybe that's as close to diagnosing it as the Receptiva test would be.
Yeah.
Let's pretend for a second that tests were free. And I would say, okay, well, let's do it. And at least let's have that piece of information. But I agree with you entirely, Dr. Amos. Like even the studies looking at these very invasive treatments like Lupron or surgery, if you did those things versus not doing anything at all, you see a bump up in pregnancy rates, but it's not like a 50% increase or 100% increase. It's like a 10% increase or, less than 15% increase. And so what this is telling us is that there's clearly some people that are benefiting from this treatment, but most are not.
Yeah. And
our treatment is, not that fancy. It's just suppressing the endometriosis or surgical treatment. So I don't know. I do think that once you start running into some issues where things aren't going as smoothly as you would have hoped, that's when I usually tap into some of these tests like the Receptiva, or if the patient really, really has a strong suspicion or strong clinical history and they're like, I just want to know. And then we can do the Receptiva. And even then, by the way, it's not 100% diagnostic. It's just a correlation. So I always tell people that. And the Receptiva is not like a walk in the park either. You have to have an endometrial biopsy. I mean, it's not terrible, but I wouldn't sign up for it if it didn't have any benefit.
And it's not completely specific. You can have other things that can make it positive, which makes it hard to know, is it the endo, what it is? But, again, at least we know where to start looking. Someone asked a great question. You hit surgery a second ago, and they asked this question about, if you had to have surgery, would you ablate it or would you remove it? Now, I come from Mayo, and at Mayo, I would literally, they would kick me out of Mayo if I said that I would ablate it, that you always remove it. That's how we were always taught. Dr. Magrina at Mayo Clinic. I mean, I used to be a nurse, and that's what he said. But although I know there is some data out there saying that you probably don't have to remove it, but that's just how we always did at Mayo. We would always remove it. So you're removing the actual tissue and stuff. What's your thoughts on that?
Oh, yeah, 100%. I think I would have lost a finger with my mentor back when I was a fellow if I would have said, you have to ablate it. No, or you can ablate it. I mean, I think, again, this is maybe it's splitting hairs for some cases, but I think for some cases, it's really important to totally take out the tissue, do it really carefully, really meticulously. And yeah, I mean, there's just nothing else to say. At all the conferences and things that we go to too, I think that's the general consensus. Now, I want to get back to one thing you said earlier, which is if your surgeon chooses to ablate it, that's the right thing for them.
Correct.
They're doing that because that's the safest, best way that they know how to do it. And I always think that's the best thing.
Exactly. That's what I tell patients all the time. They're like, oh, I wish my doctor could have done it. I said, no, your doctor, actually, you have a great doctor because they realize their limitations And that's what you never want someone to try to do something that they don't feel comfortable with. And that means you have a great doctor. You don't want a cowboy who sits there and just tries anything they want, or a cowgirl, just to be fair. Yeah, I agree 100%. And there might be in the future, I mean, there might be immunologic therapies, where kind of like some dermatological problems where we'll be able to give someone something their body just goes there and attacks it, where we can boost up their immune system. And that would be fantastic someday if that could be done. One thing that I no one asked, but it comes up a lot is like cysts. They're like, oh, I got a cyst. Could it be an endometrioma? And there's a little bit of confusion sometimes that you'll do an ultrasound and you say, oh, that could be an endometrioma. And people are like, what do you mean could be an endometrioma? And to help explain to people if this ever comes up is that there are what are called corpus luteal cysts, which are cysts filled with blood after they ovulate. So corpus luteum or corpus luteal hemorrhagic cyst, or you can have an endometrioma, which is also filled with blood. And so they can look very similar. And so why we sometimes will say you may have an endometrioma is because the hemorrhagic cyst.
Oh, I think Dr. Amos was right in the middle of telling us something really revealing there, and it just cut out. So I'll step in here. I mean, basically, and when he hops back on, we'll let him finish his sentence there. But basically, what we're talking about here is that there are different cysts that can actually look kind of similar on ultrasound, and especially depending on when you're looking at the cyst. So, if you're looking at the cyst at the beginning of the cycle versus at the end of the cycle, they can look a little bit different. Now, endometriomas really shouldn't look different throughout the cycle. They should be stable. And endometriomas shouldn't grow very much or shrink very much throughout a cycle. They should stay stable. And so that again gets back to this point of why we very oftentimes will like to take a look at a cyst multiple times. As you're going through an IVF cycle, we always go back, take a look at the cyst, or from 1 month where you had your baseline ultrasound to maybe when you're going through your IVF cycle, we'll take a look at that cyst there again. And there was a question earlier that relates to this, and I thought it was a really cool question. It was about when we're hey, there he is. He's back.
I'm back. I was able to listen to you the whole time.
Okay.
Perfectly. Thank you.
No, it's not a problem. I was just gonna dive into this question that Steve asked, which is a great one about developing technologies in our field around AI analysis of ultrasound, MRI imaging of endometriosis and endometriomas. And the idea here, very simply, is that these dang things are hard to see sometimes, right? Like if you had a big whomping endometrioma, okay, that's easy. We can all make that diagnosis. But sometimes there's like deep infiltrative endometriosis or other, little nodules of endometriosis. And these are kind of difficult to see on ultrasound, even to a very trained eye. And the question is this a part of our field where AI can help, much like it is helping right now detect breast cancers on mammograms? I think absolutely. I think this is a perfect opportunity. But I don't know. What do you think? I mean, you are, you're definitely our AI, guru.
I'm the nerd. I know. Without question. And the reason why I say without question is and I know that someone who has more experience is able to diagnose endometriosis much better than someone who comes out. So what that tells us is there's definitely differences that can be seen, right, with experience. With AI, you're now able to look at even more parameters. So I have no doubt that we'll be able to. And matter of fact, there may even be a point where AI might be able to do things with ultrasound that we can't do because it can look at things, or MRI and stuff like that. So AI is going to become a big part of medicine. And, without question, I think it's going to be there. I think one thing we talked about earlier, too, and I wanted to bring up is this question about adenomyosis and endometriosis. Mm-hmm. Adenomyosis is just a form of endometriosis where it's in the muscle of the uterus. It is technically still kind of an endometriosis. It's just that instead of being on the outside of the pelvis, it's inside the muscle of the uterus. And it usually causes the uterus to get bigger and boggier because of that tissue that grows into it. So just to make sure people understand the difference between adeno and endo, they still are very similar. And so both of them if you were having problems with implantation, you would still do things like the Receptiva test and things like that. So
Right.
Jumping from that, question came up was Jennifer Ann said, can you speak to the Receptiva test versus ultrasound and MRIs for the diagnosis compared to surgery? And this is interesting because I get this a lot. People think the Receptiva is a diagnostic test, and it is not a diagnostic test. It is not made to find out if you have endo. And I've heard people say that sometimes. They'll say, like, well, I'm going to go get a Receptiva to find out if I have endo. I'm like, what? That doesn't mean you have endo. I said, if you have endo, you might have positive BCLS6, which could be related to your endo, but finding BCLS does not mean you have endo. I mean, there's, that does not in any way give that. And so, what is your thought on that? I mean, MRI, again, and for surgery is the gold standard, but as Steve Rooks was saying, I mean, these other tests coming out are going to be pretty dang good that we might not have to do surgery anymore to diagnose it.
Yeah, or even surgery might change. I mean, I was just reading a paper recently about sclerotherapy, where they're injecting, 95% ethanol into a cyst, into an endometrioma percutaneously. So no surgery. They're just doing it under guidance of an X-ray, basically. So they're just putting a needle into the endometrioma and basically, dissecting the cyst, or killing the cyst, let's call it. So even our surgical managements might change in the future. And this could be something maybe we could even do in the office. I mean, how wild would that be if you can start offering some of these things? But I agree. I mean, I think there's a huge gap between what we have currently to screen endometriosis. That's the word I use. Screen for endometriosis. And then to make the definitive diagnosis, really the only thing we still have is surgically, you go in there and you take part of the tissue and you look under the microscope and you say, yep, that's endometriosis. And between those two things is a big gap. Now, are we closing that gap a little bit with some things? Yes. Really, very strong radiologist with an MRI can very accurately diagnose endometriosis, or, a very high resolution ultrasound in the hands of an REI who's interested in looking at these things can do it as well. And these molecular markers are very important and probably the way of the future. But just like you said, Dr. Ramos, I mean, they are not super specific yet, meaning that it could be other stuff. It could be you have a dilated tube. It could be this. So part of it is that whole clinical picture. It's like you want to make sure that you really think this person has endometriosis. Then you do the test. Then the test gives you more information. Yeah.
And when you're trying to diagnose it, like you said, I mean, ultrasound's not very good, but in the right hands, if I see an endometrioma, I'm probably going to be right like 98%, 99% of the time that they do have endo. I have seen a case where it did look like an endometrioma and went in there and it actually was just a hemorrhagic cyst. But technically, if I probably would have waited longer and longer, she was in pain, we didn't wait as long, it would have went away and we would have realized it was a hemorrhagic cyst. MRI is a great tool, like I said, and you're right. In the right hands, radiologists can do it. I really think there's going to be a huge benefit, because I think when we get those tests that are non-invasive, we can use that and go, is it even worth going to surgery, right? And then that's when you can go, hey, it's going to be worth it now. There's a high chance we're going to find it. We can debride it. Someone was asking about adenomyosis, and obviously that's a tough one too to diagnose. I think radiologists are going to be a little bit better. I had a patient today who was, made the comment like, oh, the doctor never saw the adenomyosis, and I found out like after, so many ultrasounds, and I tried to explain to them, it's not always obvious. There's some that are just blatantly obvious. I mean, it looks like there's like almost like a fibroid like picture, and you're like, oh, that's adenomyosis. But when it's mild, I mean, it's very hard sometimes to determine on some people. But diagnosis wise, really the true only diagnosis for adenomyosis is taking the uterus out and then cutting up the pieces and finding it. So I know there's some other people doing some other types of tests looking at it as well, like MRIs and things like that. Anything you have to add to adenomyosis? I know we're getting near the end here, so I'm trying to run through people's stuff as we get near the end here.
No, I'm totally obsessed with adenomyosis, because I think it's really underdiagnosed, and it's really, really hard to diagnose mild cases of adenomyosis. And again, if I had to guess, I mean, I could believe that endometriosis can kind of invade into that muscular layer of the uterus more than it goes to other far-flung spots microscopically. And that could probably pretty significantly impact, implantation for some women. Of course, the question is, okay, so what do we do about that? And we don't have any perfect solutions quite yet, I would say, but there are many things that you can do to somewhat help the environment, to kind of decrease the inflammation, help the environment to some extent, so that when you put a great embryo in there, it has the best possible chance it can have to implant.
Yeah. I know we're kind of at the end here. We had one last person come up, and I know I was gone when my camera disconnected. So I was thinking, why don't we let KJ in here, we'll have him ask a question, and then we'll kind of call it a night. But I mean, I just want to tell you, it's been quite engaging, lots of questions tonight. This is really a fun show, and I enjoy answering the questions more than anything. So, KJ, you have a question for us? I think you're on mute at the moment. Let's see if I can unmute your mic. No, it won't let me. You have to unmute it.
Can you hear me?
I can. We can hear you.
No,
Yeah.
I just kind of came in late. I've been with the clinic prior, and someone I know that is with you guys now that I referred has endo. So I was just kind of listening in just to get some knowledge.
Absolutely. Do you have any questions for us, or?
I don't think so. Is this whole podcast will be available after the fact?
Yeah, so it will be on YouTube, and some of the social media accounts will be there for viewing.
Okay,
Yeah.
Great. I
Well-
appreciate it.
Well, thanks so much, KJ. Well, I just want to thank Larissa again. I think she had some great questions for us. I think that helped us kind of guide the talk tonight. And in the is there someone else who came on again at the very end here? In the end, I think the most important thing here is, and what I saw from all these questions people are coming in, is this: it's never wrong to question if you have endo. Ask your doctor. No one can ever say no 100%. When I used to work with a doctor named Dr. Javier Magrina, probably one of the best surgeons when it comes to endometriosis, he was at Mayo Clinic. And, he would tell me all the time that if someone even has a couple of those symptoms or one of those symptoms, and you do these microscopic biopsies, you'll find it. And so I started doing surgeries. I didn't see any endo. And I started doing all these biopsies in front of the bladder, next to, in the posterior cul-de-sac, everywhere. And they would always come back positive. And so the point is that it's not just about if you have endo, but the question is, does it affect it? And that's, I think, a very important thing, because I think fertility is so stressful to begin with. And, when you start then thinking, oh my God, now is endo causing a problem? I think the thing to understand is not that your doctor doesn't think you might have endo, but it may not be on the priority list of things causing problems. Because like I said, you can have the worst case of endometriosis in the world and not even know it, have 3 kids, and then one day you're going to get your uterus removed because you're having heavy periods, and they go, wow, you had severe endometriosis in here. And you can also be someone who has pain every day, like Larissa. Could be like a little dot of endometriosis, just a tiny bit of it, be in severe pain every day and struggle to get pregnant. And so it's just important to understand that in that workup, they're going down it, but they're also looking at you saying, hey, I don't want to put this person through a surgery because I don't want to put them through a surgery if I don't suspect it's going to benefit us. And so it's not just do you have it, it's a question if it benefits. And unfortunately, as you probably have learned in fertility, it's a lot of trial and error. And so sometimes you do a transfer and it doesn't work, and you go, okay, now we got to look at Receptiva. Or you do an IVF cycle and the quality of the eggs are very important. You go, okay, there might be something more going on here that's undiagnosed. And so it is, unfortunately, some of that trial and error. And just want to prepare people for that, because endo is an enigma. I wish I could say I'm a super expert on it, but no one is, because no one knows it well enough. And I'll leave it at that. And Dr. Shimon, you give your last part, and really appreciate everybody.
Yeah, no, definitely. I mean, I definitely agree with so much of what you're saying there, which is that, there's a reason it takes so long to diagnose endometriosis, and it's in large part because it's difficult to diagnose it. It's hard to uncover it, and sometimes just diagnosing it is so invasive, surgery, et cetera. It's like, is it going to really make enough of a difference to be worth it? You know, we see people kind of further along, you know, the benefit of kind of Monday morning quarterbacking, if you will, you know, being like, oh yeah, you've had painful periods for 6 years and infertility. Let's look for endometriosis, and then we find, and then we look good for a minute. But the reality is that, you know, I'm sure that, you know, if we were the ones at the very beginning of your journey looking at it, maybe we wouldn't have jumped the gun to say, hey, let's go do this right away, or let's do that right away. So I really do want to give credit to all those OBGYNs out there, all the NPs, all those, you know, various providers who, you know, don't have the benefit of Monday morning quarterbacking. You know, but I think the other part of it is, I hope we move the needle on this. I hope that new technologies, new interventions, new diagnostics make it so that women don't have to wait 9 years to get diagnosed. And especially if they're having pain, that their pain can be dealt with beforehand. And that I hope we get to therapeutics that allow us to deal with both the pain and the fertility in the near future. And I think we are going there. And in the meantime, you know, treatments really have to be very individualized to the specific individual and the specific couple.
Yeah. And one thing before we go, and again, if I've ever had to say for my daughter, if I thought she had endo, the one thing if she asked me is like, Dad, should I go do surgery? I would tell her it should be the absolute last resort. I've never seen anyone do a surgery and then go, I've never been great the rest of my life, never had another problem. Like, there's always, it comes back. And so, and once you start those surgeries, it becomes like, you know, they start racking up. You start doing more. I just wonder what's your thought on that too. I mean, do you have that same belief that it should be the last resort type of thing? You shouldn't do it, but just one of the last resort things you do.
I don't take it lightly one bit. I think it should be kind of reserved to that last resort. Totally agree with you. It's very common that it's one surgery. It's not usually it's not about, you know, if you'll ever need another surgery. It's more about when you'll need that next surgery.
Yeah, exactly. So, well, thanks so much, Dr. Salem, being here with me, and always have fun. Sorry, guys, if we didn't do it the 2 weeks before. Unfortunately, we had a fatality in our clinic and in my family, and it was just a little too much to do it. So I do apologize for that, but we're back at it again, and we'll see you guys again in 2 weeks. So thanks so much. Have a good night.
Bye, everyone.
Bye-bye.